May I kindly invite our two panelists, Dr. Hesham Al-Dahab and Dr. Youss Al-Shamali, along with our case presenter, Dr. Maryam Al Khateri, to present the next session.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank Dr. Hiba Al-Farhan and the faculty, Dr. Ahmed Al-Fadli, for this kind invitation. And I would like to congratulate you for this successful meeting. It's, as usual, shining in the GCC. Today, I will give you a brief idea about endobariatric procedure. The challenge thing here in my presentation that we don't have that much clear roadmap and guidelines for endobariatric procedure. Over the past decade, bariatric surgery has gained popularity in the treatment of bariatric procedure in weight reduction and metabolic disease. However, gastric remodeling techniques are gaining wide adoption and getting better as far as stability and impact on weight loss and comorbidities. This is the spectrum of obesity. We can see that from the axis of the invasiveness to the axis of the effectiveness that we had a gap between lifetime intervention and bariatric procedure. There has been implantable devices like intragastric balloon and a sleeve liner, but we were mostly operating in the zone of 10 to 5 total body weight loss. But now, in the presence of gastric remodeling technique, we're going to augment both the magnitude of the weight loss and the durability of the weight loss in order keeping the safety that can provide by endoscopic procedure. The gastric remodeling technique available now, we have overstitch or endosleeve gastroplasty, and we have post-2 procedure. In endosleeve gastroplasty, we are using full thickness suturing device, applying sutures from the incisura up to the proximal part of the stomach, resulting in reducing longitudinal axis of the stomach and tubulizing shape of the stomach. While in post-2 procedure, we are using certain plication, and each plication can decrease the size of the stomach in 6.5 centimeter. So if we apply certain plications from the incisura up to the proximal part of the stomach, we will result in tubulizing the stomach and decreasing longitudinal axis of the stomach. The third available gastric remodeling technique, Endomina, which has been invented by Jacques Devier and his team. In this procedure, they are inserting the device through the scope, and they are using special grasp to grasp the tissue inside the device itself before deploying the suture, resulting in decreasing the gastric volume, as we said. But now we have that evidence is quite mature in real world and from the clinical trials. This is a famous MERIT study which has been used to get the approval for FDA for endosleeve gastroplasty. In this randomized controlled trial, they evaluate the efficacy, safety, and the side effect and impact on weight loss and comorbidities of after having endosleeve gastroplasty. Last year, we have endorsed a consensus agreement between guidelines between EFSO and WGO, where they agreed that there is specific rule of endobariatric procedure as a primary intervention or as a revisional procedure for patients who regain weight post-bariatric procedure. But who's the candidate for this patient? We know that they announced patient more than 27 BMI with comorbidities, they are eligible to endobariatric procedure, while the patient who's more than 30 to 40, they can also be candidate, but more than 27 should be with 1 or 2 comorbidities. Usually, the procedure is safe with minimal invasive side effect, and the expected weight loss for these patients, more than 17% with endosleeve gastroplasty and 10% with gastric or balloon. Just I would like to ask my colleague here about their experience in that. How far you are seeing your spectrum of patients, class 1 or class 2 or class 3 obesity, from your experience?
So thank you. Dr. Maryam. Yeah, so by being in Kuwait, we do have significant density of a huge population with obesity. The main people that I deal with as an endoscopic bariatric physician are the people who have obesity type 1 and type 2 mainly. We rarely deal with obesity type 3. I can't remember, we did only one case who was a physician who insisted to have an endoscopic procedure to lower down his weight prior to proceeding to a surgical intervention. But yeah, mainly I would say it's obesity type 1 and type 2 are the main population that we manage and treat with endoscopic intervention, at least in Kuwait.
Dr. Hesham?
Yeah, I agree. So still the same criteria, so type 1 and type 2, and above 18, but I've seen like my colleagues in Saudi Arabia have extended the indications because we're seeing also obesity amongst adolescents. So a couple of cases of endoscopic remodeling has been carried out on 15 teenagers as well.
And you are working close with surgeon, bariatric surgeon?
With the bariatric surgeons, they strictly just go for the morbid obesity. So.
Okay. Here, I would like to share one of my patients who's referred from bariatric surgeon. This patient, her BMI, she's around 40 years old, her BMI 60. This patient failed twice for sleeve gastrectomy. They abort the procedure twice for this patient. Then they refer the patient because huge liver. Then they refer the patient for endosleeve gastroplasty. We did it last year. The patient lost more than 50 kg. And I started her recently on Mounjaro as well to enhance the weight loss. Then in case that if she's not achieved the target, she will go again for bariatric surgeon to do the procedure. And this is frankly what now seeing the guidelines which announced 2 months back that IFSU announced the statement for the rule of endobariatric surgery, and especially here we are talking about endosleeve gastroplasty. You can here scan the code bar for this announcement, which will be soon, 6th of February, where they will discuss all the possibility and the efficacy of the endosleeve gastroplasty, and they prove that it will be effective for class 1 and for class 2 plus class 3 in case the patient they are not eligible to go for bariatric procedure, and they prove that it's having strong impact on metabolic disease like diabetes and hypertension. This is another study which has been published by our colleague here in region, Dr. INT'L Qahtani, where he evaluated the endosleeve gastroplasty with sleeve gastrectomy, and they found that the total body weight loss achieved with endosleeve gastroplasty was around 14%, while the patient achieved more than 19 with endosleeve gastroplasty. They show both of them significant result in the improvement of metabolic disease, but on the hand of focusing on the side effect, we can see that the side effect of endosleeve gastroplasty is minimal, although they found that there is a possibility of having GI bleed more with endosleeve gastroplasty. I don't know from your experience if you develop any side effect with the endosleeve gastroplasty?
So from my side, regarding the endoscopic sleeve gastroplasty and the other modality for gastroplasty as well, such as post-2, honestly, it's rarely that we have a bleed. And the good thing is that whenever you have a bleed, it's usually managed most of the time, 100% of the time, actually endoscopically, either with the placing clip or suturing the same area that was bleeding. So I think bleeding is not a huge concern for me, at least when I'm doing the procedure, and it's good that you know you can control it at the same time.
Yes, I agree. So they reported the incident is 2%, so either deal immediately with suturing or they present with delayed bleeding, and again you treat it with suturing.
Exactly, and sometimes we are just waiting, and after deploying and the cinch, the bleeding will stop. I had one patient only who came after 1 week with GI bleed, And this patient, endosleeve gastroplasty was done smoothly, the patient discharged, but unfortunately, patient was developing COVID, and at that time, they started to give him anticoagulant. Then the patient came with GI bleed, and which was stabilized by hemostasis, single clip were applied for that artery. Talking about the metabolic effect, also I'm here sharing with you the study which has been published from our center, where we evaluated the improvement in the steatosis in patients with obesity who underwent post-2 procedure. In this study, we enrolled more than 40 patients. 20 patients underwent post-2 procedure, and 20 patients choose lifestyle. And in that procedure, and we follow these patients initially 3 months, 6 months, and 1 year, and we found that there is significant improvement in the control attenuated parameter for the patient at 6 months, which continue to be more significant after completing 1 year. And 53 of patients in post-2 arm, they achieve they achieve F0 after completing 1 year. I don't know about your experience. I don't know about if you noticed that most of the patients who underwent endosleeve gastroplasty, endosleeve gastroplasty, they are not worsening reflux. Do you have any experience about that?
Actually, this is one of the advantages, that you don't get much reflux with the remodeling compared with the gastrectomy.
Yeah, totally agree. I think it's more related to the way that you do your suturing and your suturing technique. I think it plays a huge role. The pressure is not too high as well, and sometimes even I had a patient actually she had reflux, and that's why she was advised to proceed for bypass rather than a sleeve gastrectomy, and that's why she decided to come to us to have the ESG, because she doesn't want to go for bypass. Her reflux actually improved afterward. Again, it's mainly the technique of suturing, how you do it, and yeah, I didn't see any significant symptoms regarding the reflux with our patient, at least.
Yes. Totally agree. And here I'm sharing with you, this is one of our study where we evaluating the effectiveness of TIF or fund duplication with endosleeve gastroplasty. We presented during the last FSO meeting, and we found that there is a significant improvement in evaluation in all parameters. All of these patients underwent Bravo capsule endoscopically, and then 3 months, 6 months, and 1 year. After that, and the questionnaire, we found significant improvement in both the reflux disease and also a part of weight reduction. Now there is rule also for endobariatric procedure as a revisional case for patients who regain weight post-bariatric procedure. In revisional procedure, what we are doing, we are resizing the dilated stomach dilated stomach with sleeve gastrectomy, or we are resizing the gastrojejunnal anastomosis in patient who has wide gastrojejunnal anastomosis post-bariatric procedure. This is one of our study, and where this is multi-center study where we evaluating revisional endoscopic sleeve gastroscopy who regain weight after sleeve gastrectomy, and we found that there is significant weight reduction for these patients, which sustain for more than 1 year. This is another technique. We call it TORI, and in this procedure, what we are doing, we are using ABC according all over the gastrojejunnal anastomosis, and with using full thickness suturing after that. Usually in this, if the patient underwent only ABC alone, he will need multiple sessions to achieve the same target if the patient underwent ABC and full thickness suturing device. I don't know your experience in that, doctor.
So actually, the result regarding the weight loss, these patients lose about 10% of their total body weight by going through a very short procedure. It's just a 20 minutes procedure compared to going to doing a distalization or huge surgery to deal with their obesity and to lose their weight. Honestly, in Kuwait, I didn't start that yet, but I've done it a few times in Spain, and the result was very good, actually. I don't know if you've went through that.
Yeah, same here. We didn't get any referrals so far from these surgeons, and but they have a lot of cases that they reported mainly after the gastric bypass rather than the gastric sleeve.
Yes. Also here I'm sharing with you a new technique. We presented this study, pilot study, during the previous ACG, where we're using bariatric anastomosis reduction system from Obisco, its reduction system, and we use it for patients who regain weight post-bariatric gastric bypass procedure. And we evaluated this clip for 1 year to check the durability of this device to be in place. We found that there is 2 patients who had dumping syndrome. They improved the symptoms after completing 1 year. The last slide here, the novel procedure. It's here. This is a new novel procedure, which is already innovated by Michel Garnet, the godfather for sleeve gastrectomy. And in this procedure, they are asking the patient to swallow the small device of magnetic, and then the device will be adjusted laparoscopically for the patient, and the 2 devices will attach to each other. Necrosis will take place after 2 weeks, then the anastomosis will be there. The initial data is promising, but more data we need for this study. So the GI, by that I conclude, the GI tract is has a central role in weight and metabolic regulation. Endoscopic metabolic have demonstrated durability and significant weight reduction. Future is bright with multiple innovation in the pipeline. But we have to keep in our mind that before taking any patient for any weight loss surgery, multidisciplinary team is the key for effective obesity management. Thank you.
Dr. Maryam, I would like to ask you about your experience with patients who have advanced liver disease. So we know NASH improves, and you showed us actually data, but did you go further on and did the procedure for patients who have cirrhosis or fibrosis, at least F2, F3?
Cirrhosis, there is one patient was referred with fibrosis F4 and cirrhosis, but without varices. The patient was planning to undergo for liver transplant, and they were asking for balloon, not for endosleeve gastroplasty.
Nice.
Yeah, and show significant improvement, of course, after weight. He started to lose weight, but we haven't followed the patient. Only we removed the balloon after he lost more than 25 kg, and he was following with hepatologist.
Great, thank you.
We are more delicate. They are more aggressive. I don't know why the medical is less weight reduction.
Both of procedure is restrictive procedure, but the pathophysiology for both procedure different than the other. So we still far away from to achieve the same target of a bariatric surgeon. Therefore, we are doing things to enhance the durability of the procedure itself by inducing ESD, by doing ABC to enhance the healing process for the suture. Because at the end, this stitch, if the patient will eat earlier, it will lose the efficacy.
Thank you very much, Dr. Maryam.
Thank you. Thank you.